Assalamu alaikum. Today we are going to discuss about the breast carcinoma and mainly ductal carcinoma in situ. In front of you there is a slide which shows the morphological classification of the breast carcinoma. There is another type of classification, that is molecular classification, and that classification is also frequently asked in your exams. I am telling you here so that you may not ignore that classification as well, but here I have shown you the morphological classification of the breast cancer, which includes one is carcinoma in situ or non-invasive carcinoma, and another one is invasive carcinoma. Invasive carcinoma involved ductal, lobular, invasive ductal carcinoma and invasive lobular carcinoma. These are main types of it, and some other types like medullary, mucinous, papillary, tubular, adenoid, inflammatory. And in the case of infiltrating ductal carcinoma, almost it constitutes maximum of the cases of the invasive carcinomas of the breast, which are almost you can say that roughly it is 75 to 80% of the cases. Number two is infiltrating lobular carcinoma, that constitutes almost 10 to 15% of the cases, and in minor cases these are all are involved. Okay, so in the case of carcinoma in situ, there are again other two types: ductal carcinoma in situ and lobular carcinoma in situ. In the previous video, fibroadenomas morphology, I have told you that what is the normal anatomical structure of the breast. You can watch from there too, but for your revision or recall, let me show you here again the anatomical overview. That you can see here that this is the terminal duct. These are the terminal ducts of 3 to 5 acini. Okay, and they together form a lobule, and these ducts then join to form a large duct, which is lactiferous duct. Here the name indicates that it is ductal carcinoma in situ, so it may involve only the ducts, but no, it involves the lobule as well. But in this case, as this tumor from ducts grows and grows, and it involves the acini and involves the whole lobule, and the architecture of a lobule is not retained. This whole structure retains the appearance of just a duct. That is why we call it as ductal carcinoma in situ. So we can say that ductal carcinoma in situ is a misnomer. It is not only involving the ducts, it involves the lobules as well, but only and only a feature why we call it as ductal, because it causes the lobular appearance to be distorted as well, and that lobule is also converted into a duct. I hope so this will be clear. Okay, so let's start with ductal carcinoma in situ. Ductal carcinoma in situ, by definition, either it is lobular carcinoma, either it is ductal carcinoma. You will say that this type of carcinoma is confined you can say that this type of carcinoma, which is carcinoma in situ, doesn't invade the basement membrane. It is confined only to the basement membrane. Let me show you another diagram. Like here, this is the normal breast duct shown here. These are the luminal cells, and in somewhat I don't know which color is this. Here you can see that these are myoepithelial cells, as the ducts of the breast are lined by two types of cells. One are luminal cells and the other one are myoepithelial cells, and in this red color is the basement membrane. Okay, so the carcinoma, which is carcinoma in situ, will not invade that basement membrane. It will be confined to that basement membrane. Here you can also see that it is ductal hyperplasia, but the cells are dividing fastly. And here ductal hyperplasia with atypia, where some atypical features of the cells can also be seen. This is ductal carcinoma where the whole duct is involved, but this carcinoma is not invading this red colored basement membrane. But here ductal carcinoma in situ with invasion, here you can see that this carcinoma has also invaded outside the basement membrane. So it is ductal carcinoma in situ with invasion, but this is actually the ductal carcinoma in situ with which we are concerned today. So that was all. I have told you the definition that you must tell in your exams, that it remains confined to the basement membrane. It doesn't invade the basement membrane, in other words. And it involves both the lobules and ducts, but it changes the architecture of the lobules into the ducts. So it is ductal carcinoma in situ. In morphological types, there are two types of, in morphology of ductal carcinoma in situ, there are two types of ductal carcinoma in situ. One is the comedotype and the other one is non-comedotype. In non-comedotype, all these things are involved. Okay, in comedotype, actually there is, you can see that there is an area of central necrosis, so we call it as comedotype. Okay, in comedotype there are two features. One is that there is an area of central necrosis which is shown here, and number two is that here tumor cells are present with pleomorphic high grade nuclei. This is the feature of the comedo, which, and these two features will not be present in this non-comedotype. Non-comedotype involves cribriform. Cribriform actually has somewhat cookie cutter like spaces, like here shown, here shown, here shown. It has somewhat sieve like appearance. You must have must have seen in your homes as well that what a sieve looks like, and similarly here you can also see that it has somewhat sieve like spaces, or somewhat you can say that here pores are formed. Okay, in other type, there is micropapilla, where complex bulbous protrusions are formed, and these are very small papillas formed here, and these papillas are without fibrovascular cores. Okay, and in papillary type, there are true papillas. Here, I will show you the zoomed out diagram as well, where true papillas are present, and here fibrovascular core is also present. See both of these difference as well. In papillary carcinoma, okay, one more feature is that in ductal carcinoma in situ, only the luminal cells are destroyed and the myoepithelial cells remain preserved in this case. But in this particular type of non-comedo type, papillary carcinoma, here myoepithelial cells are also destroyed. It can be your MCQs. In solid type, there are solid sheets of cells within the ducts or lobules, but they are confined to their membranes, right? Again, you can see here that this is the comedo type with central necrosis, this is the solid type, and this is the cribriform type, where cookie cutter like spaces or sieve like spaces are also present, or pores can be present. Here you may say in layman language, here micropapilla can be seen, but these papilla are without fibrovascular core. Again, here just recall in your mind that what it looks like. It looks like a cookie cutter. Okay, or you can say that somewhat sieve like spaces are present here, so it is your cribriform. And this, there is an area of central necrosis. Okay, so outside it there are high grade, you can say that high grade nuclear cells. Here you can see papillas. This is papillary type. Here you can see micropapillas. Here is another picture that I have explained you before. Here you can see that this is ductal carcinoma in situ, as it is very much confined. I will show you in the next videos about, I will tell you about invasive carcinomas, and you will see that invasive carcinoma is not so much confined like here. You can see it that it is a solid type. Here again you can take screenshot of it. Comedo, cribriform pattern, solid pattern. This is these are micropapilla, this is papillary pattern, and this is mixed type of pattern. Okay, so that was all about ductal carcinoma in situ, and I hope so this will be clear to you. And one more thing is that there are two features which you must know, or you must tell to your examiner, that there are two features on the basis of which we can predict that local recurrence can occur or not, or you can also see that either this particular type of carcinoma in situ will progress to invasion or not. These two features are nuclear grade and necrosis, not these architectural subtypes. On either it is comedocribriform, solid, micropapillary, papillary, or mixed, all of them have equal chances for local recurrence and for invasion as well. The only two features which will tell you that either invasion will occur or not, or local recurrence will occur or not, these are high grade nuclei, and number two is necrosis. So thank you very much.